Welcome to the People's Health Briefing, a component of the Trusted Voices campaign. I'm Dr. Noha from Roots Community Health Center, reporting for the week of January 31st, 2022. As health professionals rooted in Oakland, serving some of the people most vulnerable to getting and suffering from COVID-19, we're here to cut through the noise to give you information you can use to make choices that will keep you, your loved ones, and your community as safe as possible. The goal of the People's Health Briefing is to empower you with our best knowledge and thinking every Tuesday morning. Daily cases in Alameda County, much like in the state, do appear to be coming down from this incredibly high, unprecedented surge that we've been experiencing within this past month. And the last 7 days there have not quite been reported, but both our 14-day average is coming down as well as our 7-day positivity rate. Our 7-day positivity rate for Alameda County reached an all-time high of the entire pandemic on the 18th of this month at 18.9%, and it is currently at 13.4%. So even though we know that that's becoming kind of a less and less reliable measure as more people do home testing, it is still so astronomically high that it is definitely is reassuring to see it coming down. Hospitalizations are coming down a bit as well, and compared with last time I reported last week, it was at 428 individuals in the hospital with COVID. We're now at 416, so it appears to be heading in a good direction, but unfortunately ICU cases are trending up, and as we know, kind of those worst indicators tend to be lagging. And so, as we know, unfortunately, likely deaths will also continue to increase from this point going forward from this surge that we've just experienced. So far in Alameda County, 1,606 individuals have lost their lives to COVID-19. That is an increase up 28 individuals from when I reported last week. We know those numbers and the reporting for that is not perfect, but certainly we're going in the wrong direction there, and anticipate that we'll continue to do so just based on how the surge we've been experiencing this surge. And an additional 4 individuals in skilled nursing facilities have lost their lives to COVID compared to what I reported last week as well. And so unfortunately, we are bracing ourselves for a little bit of what is still to come in terms of that what we call a lagging indicator, which is deaths, which trail behind cases, then hospitalizations, then deaths. In terms of vaccination rate overall in Alameda County, we are continuing to tick up, and we have 81.4% of Alameda County residents fully vaccinated, so this is impressive. 56.8% are fully vaxxed and boosted as well, so that's continuing to tick up. But we still have big disparities here, and our 2 racial ethnic groups that have the lowest vaccination rate are African American and Latino at 65 and 66% respectively fully vaxxed. So 65 and 66% compared to 81.4%. So 16 points lower. That is a very significant disparity. And this will lead directly to disparities in both hospitalization and death because, as we know, and I reported here week after week, those who are dying and becoming hospitalized are those who are unvaccinated. So you can see that that is how, unfortunately, these disparities will continue to widen if we don't correct this disparity in vaccination rate. In terms of age group, our lowest vaccination rate age group by quite a bit is the 5 to 11-year-old age group, which are still under 50% fully vaccinated. And so we're off to a very slow start here in Alameda County and really across the country with vaccinating young children, and it is understandable that parents really wanted to see ample data before making any decisions, but we have that now. We have that data now. I went over it in a lot of detail, citing multiple sources at the December 21st People's Health Briefing. The link with the relevant time code is in the post, and I strongly encourage you, if you are the decision maker on behalf of a child, or you know someone who is and they have not had their child to get the vaccine yet, I encourage you to please review this information, send the link, have them or you speak to the child's pediatrician. Do your due diligence to get your questions answered. This is not a situation where we can put our head in the sand, because it's another one's life in your hands and their future, their development. So I don't have to tell you this is serious business, and I know we all take this seriously, and sometimes that can make it really hard to take a proactive step. But to be clear here, the issue that we have with unvaccinated children is not so much about death, although we have lost too many children already to COVID-19. And that number, unfortunately, is increasing now more than it ever has. And that's very disturbing, because this is now a vaccine preventable illness. So even losing one child to a vaccine preventable illness is really unacceptable. But to have the rate increasing at this point, this far into the pandemic, is really just unacceptable. And it's not even so much about hospitalization, although really it is incredibly disturbing to have your little one in the hospital, struggling to breathe and suffering from an illness like this, especially at this time when our hospitals are stretched and challenged. But to me, and mind you, I am coming at this from a family physician perspective and a parent perspective as well, and really thinking about people's quality of life and their health for their lifespan. There is just too much about this infection we do not yet understand. We don't know the full impact of this infection on those little developing organs. And what we do know, and we're seeing, we don't like. We are seeing new onset diabetes. We're seeing issues with the heart, with the lungs, with neurological issues. And there will be more that we discover as time goes on. So we really don't want to risk these small developing bodies to an infection where we don't know everything about it. And really, if we can avoid it, we don't want to find out. We don't want to find out. And we know enough already to know that we don't want to take chances. And when we look at what really is an impressive safety profile of the vaccine, it makes waiting seem that much more pointless. What is it that we are waiting for? We know enough about the safety of the vaccine. We know enough about the harms of COVID-19. And we also know that there's a whole bunch more that we don't know that could be even worse than what we do know. So go back and you can you can go back and hear me speak about the vaccines before they came out, and I made no bones about the fact that we are not going to recommend a vaccine for children unless we are very impressed and very convinced about the safety, in order to recommend it for our own children and for the community, because the last thing we're going to do is allow for harm to be done by a vaccine to our children. And really, with all of the age groups, all of the groups, we're seeing that the vaccines are impressively safe. But where they are the safest, where we haven't seen one single safety signal in the 5 to 11-year-old age group, not one. So really, arguably, it's the safest in this age group. And so, if you're the parent or you're the caregiver for a little one, the decision maker for a 5 to 11-year-old, you may have to take some deep breaths. You may need to pray on it, but go on and get all your questions answered. Once you get those little ones vaccinated, you can then breathe a sigh of relief. Be reassured that the risk of catching it and having some of these concerning manifestations is much reduced. The chances of them spreading it to someone vulnerable is much reduced, and you can rest assured that you have taken the most critical, irreplaceable step to protect them from the most serious of outcomes. And when I say the most critical and irreplaceable step, what am I talking about? Well, I'm talking about something that I'm hearing a lot lately, and I touched on this last week, that they'll skip the vaccine step and just opt for these outpatient treatments that they're hearing about if they get sick. So they'll skip the vaccine and then they'll just get outpatient treatment. They'll get pills, they'll get monoclonal antibodies if they catch it. So, first off, I want to say that these treatments are really for 12 and up. So right off the top, the 5 to 11-year-old age group is not even eligible for treatment. But also, regardless of what age you are, waiting for treatment may be too little too late. And I'm going to go into a little bit more detail on this in a moment. But really, I am hoping that someone out there can explain to me why anyone would want treatment but not the vaccine. It's a bit baffling to me. I'm going to unpack this a little bit, but if you know the reason or if you're in this camp, please enlighten me in the comments or by direct message or by email to admin@rootsclinic.org so that I can speak to this better, that I can understand this better. And so, in the meantime, what I'm going to try to do is explain this in the context of something that we talk about a lot in public health, and you may have heard about this before when we talk about upstream and downstream approaches, and how if you're trying to prevent something from getting real bad, like you're trying to prevent the dam from flooding or the river from overflowing, you're going to go upstream and try to take care of something up the stream instead of waiting until we get down to the stream, down to the end of the stream. So we're going to try to prevent something or go to the root of it. We want to go upstream to the top of the stream rather than waiting until the end of the stream where you might be overflowing, you might be drowning in the deep end, you might not be able to save them all. So we try to go upstream, and when we talk about public health and we talk about preventions, we always want to try to go as far upstream as possible. So I'm not going to do the whole big picture of COVID today, because if I did, there would be a whole lot of things upstream, like better access to primary care, better ventilation in our buildings, better masks for everyone, paid sick leave for everyone. I could go on and on. And maybe I'll do that another day. But right now, I want to focus on COVID pharmaceuticals. And so, if we think about pharmaceuticals, if we're going up the stream, we're talking about vaccine, because that is where we can actually prevent people from the most serious outcomes. We can prevent them from actually needing to go all the way down the stream or ending up all the way down the stream. Next, after that, we have what's called pre-exposure prophylaxis. I've reviewed this in previous briefings, but this is for people with severely compromised immune systems that can get a monoclonal antibody cocktail by a injection that can protect them for up to 6 months. And this is before they ever get exposed, before they catch COVID. So that's why it's also a little upstream there, because this is before even getting exposed or catching it. This is prevention as well. So the vaccine and the pre-exposure prophylaxis are before you even see the COVID. You already have something on board that's going to help protect you from the worst outcomes. Post-exposure prophylaxis, if you can get it, is something that after you get exposed, maybe you can get some monoclonal antibodies if you're high risk that hopefully can prevent you from getting sick. These have been in scarce supply. And actually, the further we get down the stream, actually, some of these things are not in great supply, particularly the next step, which is the outpatient treatment. Outpatient treatment has to be started within 5 days for the pills, 10 days for the monoclonal antibody infusion treatment. And at this point, you're really, just hoping it works. It's not bad, but it is nowhere near as effective as the vaccine at preventing the most serious outcomes. At this point, we are just hoping for the best now. We're hoping we catch it in time, hoping it works for you, hoping you don't have any contraindications, right? We're hoping you're not on any medication that makes it to where you're not eligible for this treatment. We got to get you in that window of time. So this starts to become more and more dicey, and we risk kind of losing you, getting caught up and getting caught all the way down the stream where you might be flailing around in the deep end here, having to go to the hospital for that last one there, inpatient treatment, which is something we often talk about as we call it the deep end. Now you're in the deep end. Inpatient treatment. Now we're talking oxygen, we're talking steroids, we're talking IV medications, we might be talking intubation and going on a ventilator, going into the ICU, getting assistance with your breathing, and a whole lot of prayer and a whole lot of hoping that you pull through. And at this point, it is less effective, and you may not have access, right? Our hospitals are full. Outpatient treatment is certainly of limited access. And right now, just like this whole pandemic, why have I been harping on monoclonal antibody treatment the whole pandemic? It was the only outpatient treatment we had for quite some time. But who was getting it? The VIPs were getting it. The former president got it. People with money, people with resources, people who have their physician on speed dial, that's who's getting it. Not necessarily the average person who caught COVID, who lost their lives, who didn't make it, who didn't survive. So, the part that has me a little baffled when we look at this whole continuum here, vaccine, pre exposure, post exposure prophylaxis, outpatient treatment, inpatient treatment, these things are roughly made by the same manufacturers. The most desirable, in my opinion, outpatient treatment we have is Paxlovid. Guess who makes that? Pfizer, the same people that make the vaccine. So, same manufacturers, very similar trials. In fact, the vaccine trials had far more participants in them. Same authorization process in most cases. So, emergency use authorizations. And now the vaccine, the Pfizer, has a full biologic license. We even graduated from the emergency use authorization. But several of these treatments are under emergency use authorization. So, same manufacturers, similar trials, same authorization processes, but less effective and poorer access, right? What do I mean by poorer access? Well, like I said, some of these things are in short supply. The vaccine, you can get it any day. The vaccine is accessible, but treatments, not so much. Outpatient treatments are still scarce, and that is why we're going through all these different tiers. Who's the most at risk? Are you going to get it? But not only that, some of these things are subjective, right? We all know about bias in healthcare. We all know that there are decisions that have to be made when there's not enough resources. Somebody's going to get it and somebody's not. Okay, that's not the case with the vaccine right now. It might have been in the beginning where, yes, people with a lot of resources and access were the first ones in line to get the vaccines, but now it is available to everyone and it's the most effective. So it's the most effective. It had the largest trials made by the same manufacturers. Now we have vaccines with a full biologic license, so it's no longer emergency use. So why is it that you would bypass that and then wait and roll the dice with treatment? I Please email me. Put in your. I want to understand. I really truly do, because what I know is that there's a lot of subjective things that go on with who gets treatment when it's in short supply. We understand bias. We understand implicit bias, explicit bias. That means they may realize they're being biased, then not give it to you, or they may not realize it. They may think someone's more worthy of it or you, or if they have to make the choice, or it just may be totally unconscious, or it just may be that you don't have a primary care doctor you can call like that and ask for the treatment. So how are you even going to access it? So I think it's really worth saying that it's not 100% that you are going to get treatment, even if you need it. And so it just feels like a lot of risk taking to me, and it's hard for me to understand the reason why. So I'm really just asking you to think about that logic and ask yourself or your loved ones or folks that you know who may be in this camp. And it's a lot of people. I can tell you that much right now, because we are testing a lot. We see people who are positive. Haven't seen any hesitation to get treatment. Yes, get me the treatment. So I don't know if it's because at that point you're scared and you want it, but it might be too late. And that's just too tragic. It's really too tragic to keep losing people, and we are losing people. And by and large, the people we are losing are the people who've chosen not to get vaccinated. It's an individual choice. Nobody's arguing with that. I just want to understand what's the logic behind that choice when you show up at the hospital and now you're praying, hoping, and begging to get something made by the same people the vaccine was made by, and you could have prevented yourself from getting in that situation in the first place. So if you know, please help me understand. So when we talk about treatment and who could access treatment, like I say, there's a lot of rationing going on and a lot of prioritizing going on. Not everyone's going to get it. But one of the things that you should be aware of is if you would be eligible. And this includes people who are vaccinated. So this is not only for unvaccinated, although those are, again, some of the difficult decisions being made. There's a lot of people out there that think if you didn't get vaccinated, why should you jump the line for treatment when you didn't get vaccinated? There's a lot of people who feel that way. In medicine, I think that we all think that treatment should go to who is most likely to be able to benefit from that. And so it's a triaging process that has to be done. but realize that when you're triaging, that means everybody doesn't get it. That's what triage is. And when we don't have enough, there's not enough beds, there's not enough ICU beds, not enough ventilators, not enough medication, we triage. And when we triage, that means somebody gets it and somebody doesn't. So that seems like a gamble I wouldn't want to be taking. But nonetheless, if you are high risk and you may be eligible for treatment, this is really who we're talking about. We're talking about everyone who's immunocompromised, may not have mounted a good response to the vaccine, everyone who is over 65 for the same reason, everyone with clinical risk factors that will put you at risk of doing poorly from COVID-19. And there is the link, it's also in the post, to the list of underlying conditions that the CDC is recognizing. This list changes from time to time, so you have the link there. And this last bullet point for unvaccinated. So who are we talking about here? Is it everybody? Well, I think this is going to depend on how available treatment is. So if you're over 40 and unvaccinated, that is someone that I would certainly be advocating for getting treated. So is there going to be an age cutoff? We kind of don't have all of that settled right now. Does it include people who are vaccinated but perhaps unboosted? I think this is a little bit of maybe where the gray area is, and I think this is going to be directly kind of depending upon how available the treatments are. So if we have enough for everybody, then maybe we'll all just have it in our medicine cabinet, and as soon as we get COVID, we just pop some pills. But right now, that's not how it is. And I'm being a little oversimplistic because some of these pills, do have a lot of medication interactions and things like that. So again, not everyone is going to be eligible for these pills, but right now, while they're in short supply, then you just want to know if you're one of those high risk people that should be in line for that treatment, should you test positive. And so we've talked a lot in the past few briefings about when to get what test, and we have a link there in the post to this whole big algorithm. The one that I wanted to speak briefly upon today in a little more detail, because I'm getting so many questions about this, is what about after I had COVID and now it's been 5 days? What do I do? Well, what you don't do is don't do the PCR test. That is going to be positive for some time, and we need to absolutely push back against any notion that after you've been positive, you need a PCR. You don't. It's going to keep being positive, and it doesn't tell you anything other than what you already know, which is you had it. And unfortunately, we're still seeing a lot of confusion about this. And the shortening of the isolation period to 5 days has sort of added to confusion and stress around this, because we have schools and bosses saying, get back to school, get back to work on day 6. And this is a little worrisome in terms of the potential for continuing spread. So what I'm advocating for, and what many are advocating for, is that you test with antigen tests, the at-home test or the antigen test you can go and get at the testing sites. This is an antigen test, will tell you if you more or less are you contagious. So once you don't have symptoms anymore, then that will be a good time to go ahead and get tested. If you have symptoms, I would not bother getting tested at that point, because if you have symptoms, just rest. And what do I mean by symptoms? No more, so the fever. If you have no more symptoms, it means you have no more fever. It means you have no more cough. It means you have no more of that horrible headache that we're hearing a lot about with COVID, with Omicron in particular. No more achiness and fatigue. You're feeling pretty much back to yourself. If you're not sort of feeling well, then you're sick. So you need to stay home. This culture that we have in this country of playing while we're sick, playing while we're injured, working while we're sick, all of that, it's not for our well-being. And I think we need to really rethink what we mean about being well. We talk about self-care and all those things, but if you're pushing through and trying to go to work sick, that's not self-care. So just rest. And I wouldn't bother testing at that point because you're still sick. Wait till you feel better. So let's say it's day 7 and you feel better. What do you do? So let's say you have the option of working from home. You're a hybrid employee. You have the option of working from home. See, can you just go ahead and continue to work from home and do the full 10 days? That is probably, then you don't even need to really test. That is probably the safest thing to do. But if you need to get back in the mix, then go ahead and test with that antigen test. If it's positive, what do you do? So, if you're positive, it means you still got enough of that virus in the nose to be contagious. Maybe you're low level contagious, but you still got it in there and you're still contagious. And you could spread it to others. So, if you're a boss, if you're an administrator, if you're in charge, maybe just let those people who are still contagious just go ahead and stay home until they're not contagious anymore. Just a thought. Um, but don't just have people unilaterally coming back at day 6, because there's, a good chance that they're still infectious, and we have a tool. Maybe we don't have enough of the tool, but we do have a tool. We have antigen tests. And so if you haven't used them all up already, trying to establish that you had the infection and whatnot, or you can get your hands on more tests, then this is a good use of the test. If it's positive, you're still contagious. Maybe it's a low level, but you haven't cleared it yet. So number one, you still might spread it. So the most responsible thing to do is to continue to isolate. But also, you haven't cleared it yet. Maybe you need to just go ahead and relax until you clear this virus, and so that you have the time to really heal and get better, so that you can get better more quickly. Because we all know that if you try to push it, you can prolong how long you're sick, and that is not desirable for anybody. In healthcare, it's true that if people are not symptomatic, they're gonna be wearing a fit tested N95. Then there are some exceptions about them getting back to work, because we have labor shortages, we have workforce shortages, where our hospitals are stretched and stressed. So that's a little bit of a side note exception. But for the most part, can we please stay home if we're contagious? And can we please stay home if we still don't feel well? This should just be the norm, COVID or not. If you're not feeling well, then we should have that ability to stay home, and everyone should have paid sick leave. So what is next? We look like we're sort of on this little, hopefully kind of turning a little bit of a corner with this Omicron surge. We look to be on the descent. Unfortunately, some of the loss and some of the deaths that we will unfortunately experience as a community are still ahead of us. We're already unfortunately experiencing some of that now. It's hitting close to home for many of us. But we do appear to be turning a little bit of corner and going on the downward trajectory. So what next? So I don't have any reason to think that this is going to be the last wave. It's possible that this was the biggest one. We can all hope for that. We won't have another bigger one. We don't know, right? Because we don't know what's in store next. We don't know what COVID has in store. We don't know if there's going to be another variant, that could evade our immunity worse than Omicron. But so far, it appears that at least we've turned the corner from Omicron, and that, that still, it would be wise to plan for more waves. And we can certainly hope there'll be smaller and smaller waves, but still we should be prepared, right? So hope for the best, prepare for the worst. What I don't want to see happen again is what unfortunately has pretty much been happening with all of our prior waves, and that is that we get a little too excited a little too soon. We end some of our precautionary measures. We even dismantle some of the structure we've put in place to combat these surges. And we seem to have a really hard time adjusting, even just mentally, just to these surges. So, and it's been tough on all of us. I don't think anyone has been spared the stress of it all. And I would like for us to get to a point where we learn to be able to kind of adjust up and down as the conditions change. One example is, you might recall that the Bay Area counties put together some metrics where if we get to a certain point of transmission and vaccination and hospital capacity, then they will relax the mask mandates. I went over this in some detail. Now, unfortunately, we haven't gotten to this point yet. We haven't exceeded those thresholds, so we haven't gotten to that point yet. But my point is that we should and can have some measurements or metrics in place where if we go over it, then we know what we need to do. We know what we need to turn on. We know what we need to turn off. We know what we need to start or stop. And we're prepared to do that ahead of time. So it doesn't feel so chaotic or like we're just figuring it out and scrambling as we go, because that is really how it has felt for a lot of us with each and every one of these surges. And this doesn't have to just apply to health jurisdictions or counties. This can apply to schools or to businesses or even to individuals or to households. So, for example, at Roots, our planning around this includes when to have our hybrid staff who are sometimes on site and sometimes off site. When do we want to pull them off site more or bring them on site more, depending on what those transmission levels look like? Or what kind of activities can we do when transmission is low? And at what point do we want to pause those activities when transmission gets high? So these are all things that I think are worthwhile to think about, because unfortunately, if our recent history here is any teacher, I'm very concerned that everyone is just going to say, oh, thank goodness it's better now, and just relax everything and then just kind of get hit upside the head again when it gets bad. And we really, really want to safeguard ourselves against that, because it is also mentally very, very taxing to really feel that out of control. And I think by preparing, it can really help us to stay in a little bit more control over at least what we're doing, how we're responding, and what it is that we're looking at and what it is that we're looking for. And this can also apply to us in our personal lives. And so we all know that each of us feels differently about how much risk we feel we can take based on our own particular situation or just our own kind of tolerance for risk. But it may mean that when transmission is low, that's when you feel more comfortable doing certain things that you wouldn't do when transmission is higher. So for some people that might mean, okay, now I feel comfortable eating at an outdoor restaurant. But when transmission's high, we're just gonna, DoorDash or whatever. For others, it might mean, okay, when transmission's higher, I don't mind eating outdoors, but I'm not gonna eat indoors. It might mean gathering or traveling. So I think we all are going to have our different thresholds. It's not really, to me, it's not really about dictating what you can or can't do, or what you should or shouldn't do in an absolute way, but more about what it is that you're doing when you're being more cautious and because transmission's high, or what it is that you can do when you're feeling more comfortable. And we base that upon the pandemic conditions, not on our fatigue, because that is the other thing I get concerned about, is that to some extent, some of the behaviors are not so much based upon what's going on with the pandemic, but how over it we are. And we can't afford to do that, right? We can afford to relax sometimes and be stricter sometimes based on what's going on with the pandemic. We don't want to get to the point where we're so exhausted that we just give up and throw all caution to the wind. And I know that none of us wants to do this, but this has been a tough time. And I think it makes sense to have things you can look forward to. In a month, hopefully conditions will be such that, and I think indicators are pointing in that direction. Conditions will be such that transmission is lower, headed in the right direction, and some activities that currently I might consider risky won't be as risky. They won't be risky because there won't be so many people, so much, Omicron swirling around in the environment. So I will plan to talk more concretely about what some of those metrics and measures could be in future briefings. It's a little bit of a moving target because there is more testing going on at home. We can't always rely on testing rates, positivity rates, and transmission rate. But there are a number of things that are being implemented in a number of different places that can be clues and pointers. And so we may need to change some of those thresholds. But I think in overall, the principle sort of remains the same. For now, I can say that the CDC does post by county what the transmission looks like. And I put the link to that in the post. You might not want to look at it today because the entire country is red. It's not very optimistic. But as the weeks go on, I think we have every reason to believe that it will continue to improve over time. And the best thing we can do with that downtime is not to just forget it and hope that we're done, but to just put some reasonable things in place so that we can be better prepared for the next time. And so until then, please be sure to get good nutrition, some exercise, some fresh air, take a multivitamin, consider some extra vitamin D supplementation, keep your stress levels down, and get a good night's sleep. Thank you for joining us, and we'll see you next Tuesday at 10 a.m.